conference?
See, yeah, I mean, we know that Indian women, Indians as such are having a great propensity for cancer. WHO report released actually said that 1 in 10 Indians will develop cancer in their lifetime. That is quite a big number. And 1 in 15 will die of it. That means our treatment needs some more tweaking probably. And we have seen that there was a report in Lancet where it said that 6.9 million cancer deaths among Indian women were preventable and 4.03 million were treatable. So I think we have to do something about all these things. And we also know that breast, cervix, ovarian and uterine cancer comprise more than 70% of cancers in Indian women. So that means we are really, as OGCians and menopause practitioners, I think we will be able to really make an impact on our on our women. So we decided to have, November 7th was the National Cancer Awareness Day. So we had last month, we had breast cancer because it was Pinktober. And this month we decided we will have on ovarian and endometrium too. So, we will cover all cancers well. So over to Dr. Meera. Meera.
Thank you, ma'am. Thank you, ma'am. Welcome all for this webinar in November. Thank you all for joining. Hope you will all enjoy the academic treat. Secondly, following the welcome address, let us have the Tamil Thai Vartha and the lighting of Kuttuvilakku virtually.
எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம்பியந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
Thank you. Midlife prayer. We pray to God to give us grace to accept the midlife physical changes and gently renew our strength. Guide our heart, our mind and body to navigate the way and our trust in you to lead us safely through. We pray for midlife and mature women who cherish the fond moments of their life and also for those sitting in a doctor's office or who are in bed asking for healing touch on this day, may all the midlife and menopausal women have the gift of joy, hope, and good health. Thank you, God, for the promise of hope you hold out to all midlife and menopausal women and inspire us to give this gift of hope to others too. We now welcome our chief guest, and I take great pleasure and honor to welcome our past president, Dr. Shobna Mohandas, who has been a past president of Indian Menopause Society and past president of IMA Trishur. Welcome, madam. Madam has various accolades to her credit. She's been the founder secretary of Calicut Menopause Society, organized several endoscopic workshops and CMEs. Please, I would like you to address the gathering and also release our magazine, Model. Thank you.
Yeah, we are really very happy to have Dr. Shobna Mohandas. All will remember her dance exercise and of course the other academic programs too. That really made a good impact on menopause practitioners as such. And so I'm really very happy to have you. Welcome.
Thank you, Dr. Shanti and Dr. Meera, for having me here. Chennai Society is a beacon of light for the whole, all the societies in India, I think, because it's always a beehive of activities. And now it's continuing under your tutelage. And I'm very happy that you have chosen very good topics today. Because endometriosis is like you always want to put in a laparoscope, but the patient doesn't want it. It comes recurrent and you again want to put in, but that's not allowed. But if you leave it there, like you said, 1 in 10 cancers, there is a chance for going into cancer. Adnexal masses, again, today I heard of somebody, doctors coming and saying somebody had bilateral dermoid and they knocked off both the ovaries. And now should we give HRT? I said, why did you knock off both the ovaries? Dermoid is not a reason why you should knock it off. So these things, I don't know. People are scared of breaking, doing surgery for dermoid because then you have to wait for a whole lot of time washing the abdomen. So they don't want to do a cystectomy. So I'm very sure the speakers today will let us know whether we should, what to do with the endometriomas, which you leave it alone, it can go into cancer. In very rare cases, but then that fear is there at the back of your mind. And I have seen one patient going into cancer over 4-5 years when she did not operate at all for 4-5 years. And whether we should for dermoids or this thing, cystadenoma may look like functional tumor, but if you leave it alone, it can go into borderline cancer. Postmenopausal bleeding quite often is just endometritis or just little bit of polyp. The minute you see something on the pad, you are scared. So all these things, how much ever you talk about it, everybody will have unique cases, and no number of webinars are enough to thrash out all your cases here. So I'm very glad that Chennai Society has taken up this challenge, and small lamps, that kuttu vilakkas in every part of the country will light up the minds of many people. Wish you all the best.
Thank you very much, madam. Madam, we would like you to release our e-newsletter, Model.
I know how much of effort must have gone into it.
Yeah.
Can we have it like a flip? Yeah. We will share the link later in the group for everyone to have a look.
It seems to be a great newsletter with a multitude of colors and a lot of knowledge, and also it takes a lot of hard work to edit a newsletter and make it, presentable and readable, and people feel like looking at it. And I'm so glad that you've taken that effort. I don't know how many midnight oils you would have to burn to read up people who write the article, and the reading is also important. So I officially declare this newsletter to be open. Thank you so much.
Thank you, ma'am. Thanks a lot. We now welcome our guest of honor, Dr. Sumitra Shanmugam. Thank you, Madam, for joining us. Sumitra, Madam, as you all know, has been with us as a senior person, educating us for a long time. She has been with the Lifetime Achievement Award by Dr. MGR University, an Outstanding Women Achiever on International Women's Day in 2013. And she's a life member of OPSI and many more societies, working with differently able kids and their parents in Vidyasagar, formerly Spastic Society of India, and Nodayam Charitable Trust, and various hobbies to her credit apart from educating the younger generations. Thank you, ma'am, for your presence. Can we have your address to the guests, to the audience as well?
Welcome, Sumitra, madam. And madam is great, good at quilting. So I think the previous generation always used to keep on doing all those things and giving it to the needy. It is a very good hobby indeed, I think, madam. Your address, please, madam.
Shanti, thank you very much. I thank the organizers, and first thing, let me apologize for the delay in starting of the meeting. Okay, this CMS, Chennai Menopause Society, has been very close to my heart because there are so many societies, so many webinars, so many online meetings, Zoom meetings, but this Chennai Menopause Society is very close to my heart because it makes the members think and act with strategy by conducting these regular quiz programs. And the number of participants in the quiz programs is increasing phenomenally. I really enjoy those quiz programs very much, Shanti. And so today, it's a focused webinar on gynec cancer. Okay, the traditional approach of chemotherapy, radiotherapy, surgery, and all that, whether it's laparoscopic surgery or robotic surgery, they're now being reshaped by targeted therapies, biomarkers, BRCA mutations, immunotherapies, vaccines, PARP inhibitors, and so many. So many questions are in our minds. What to do? What not to do? What is happening? What could happen? When do we start all that? Do we start or do we not? So today, I hope this meeting will give us some clarity into all those things. And before that, one more thing. Chennai has been the medical tourism hub of India. And our city, Chennai, is called India's health capital. So this attracts 45% of the overseas health tourists. Since I work and go to the other hospitals in other countries also, I'm very much into this. Say there are 100 people coming into India for health treatment, 45 of them come to Chennai. That is, Chennai is India is such a popular thing, and Chennai is such a popular health center. But the reasons they come are for the eye surgery, for the cardiac surgery, for the organ transplant, knee transplant, but not for gynec surgery. So we all know that Chennai was the home to the oldest cancer institute in the country. All of us know that. And now we have some very, very good onco surgeons. We have the best cancer hospitals, both in the government and in the private sector. And more than that, we can offer cost-effective treatment with our charismatic South Indian hospitality. So I earnestly request all the youngsters doing gynec work to join in this and be involved with enthusiastic discussions. Please, youngsters, don't be just a passive listener. Think, ask questions, make others think, and that is how our society can improve as a Cancer Institute. Documentation and publications are also important. Now, I've already taken much of all your times in entering, so I won't take much time, but I would just like to finish with one slogan, which I hope all of you accept. It's CCCC, Cure Cancer with Confidence in Chennai. So it will be CCCC, that is Cure Cancer with Confidence in Chennai. Hello? Am I audible?
Yes, ma'am.
Yeah.
Excellent.
So I would like us more to promote in that kind of thing, so that it not only we treat the people of Tamil Nadu and India, but our treatment should also spread to the other countries, and we get more people coming from outside. It will become a medical tourism for cancer therapy in gynecology. That is my wish. Thank you, Shanti. Shanti and I did our MD together. And at that time itself, I used to think of her as a very studious, very honest, and really sincere hard worker. We did our post-graduations together. Remember, Shanti? In RSRM Hospital. So she's still following the same principles. Thank you so much.
Thank you. Thank you, madam. Thank you so much for your encouraging words, especially to the younger generation. We now request you to release our Chennai Express 2.0,
Yes.
which is a collation of all the activities done for the observance of World Menopause Day by Chennai Menopause Society, office bearers, and various members of Chennai Menopause Society who did a grand job for the World Menopause Day, creating awareness across the society.
I really congratulate not just doing the work, but compiling it and making it a book so that it lasts in everybody's mind and it lasts forever. Really, congratulations to all the office bearers of the Chennai Menopause Society for releasing this book.
Thank you, madam. Thank you, madam. We will be releasing these two in the group later on. Thank you.
Okay. Thank you, Meera. Thank you very much.
Thank you, madam. Thank you. We will now welcome our chairpersons. Dr. Vijaya, Professor, Department of Obs and Gynae, now currently in ESI Hospital, and special interest in high-risk pregnancy and laparoscopic surgery and fertility, national level master trainer, skill lab, safe delivery practice, and EMONG, multiple awards and publications to her credit. Welcome, Vijaya madam. Thank you for joining us.
Thank you, Meera.
Dr. T.S. Meena, who is Director and Professor of Obs and Gynae, Institute of Social Obstetrics at KGH. She's a master trainer, TNHP and CD program, and main interests are high-risk obstetrics, social obstetrics, and cancer screening, published and presented papers, and served as faculty in various national and international conferences. Welcome, Dr. Meena.
Thank you, Meera and Shanti ma'am.
May I now request you to invite our speakers, and the first speaker, Dr. Kavita Sukumar, who's a very good friend of mine.
Good evening, everyone. At the outset, I would like to thank Shanti ma'am, who is the main pillar and inspirational factor for all of us. And of course, I would like to introduce Dr. Kavita Sukumar. She is a close friend of us and well known to all the gynecologists, especially in the government sector. And she is the sole pillar of IOG, doing all the oncology surgery. And she is the course director, postdoctoral fellowship program in gynec-oncology. And she's a very, very good teacher. You must have all heard her in PG and UG revision courses. And she has done her fellowship in gynec-oncology at Tata Memorial Hospital, Mumbai. Welcome, Kavita.
Thank you, madam, for that wonderful introduction. Good evening, one and all. At the outset, I'd like to thank Meera for this opportunity. She's my classmate from MMC 90. She's basically the ringmaster of our batch. And also Shanti Gunasingh, madam, for the opportunity, and the Chennai Menopause Society as well. Madam, Shanti madam, I should take this time to tell you all that madam has been very instrumental in starting the Department of Gynae-Oncology at IOG. She took a lot of pains in doing, trying to depute me there from Trichy, and then a lot of work has been done basically because of madam. Thank you, madam. So can I start sharing my screen?
Yes, ma'am. Yeah.
So today I've been asked to talk on, one second, menopausal adnexal masses and evaluation. sorry, I didn't know I had to talk about ovarian cancer screening. So maybe I'll just add in a few, lines later on. So basically, postmenopausal adnexal masses, we are worried about ovarian masses. When you look at the spectrum of ovarian masses, you have a huge spectrum, right? From simple cyst to hemorrhagic cyst, then you have endometriotic cyst. When you're talking about in general, including the premenopausal women as well, you have ectopics, tuberculosis, PID, you can have benign tumors, borderline tumors, and then tumors of less common histology, like, granulosa cell, theca cell tumors. Then you have invasive cancers, metastatic cancers. So huge spectrum. So it's not so easy. But when you come into the postmenopausal woman, you have some of the masses which are excluded by default, like the germ cell malignancies do not occur in the postmenopausal women, hyperstimulation does not occur. So some of these do not occur in the postmenopausal women, and the incidence will decrease with advancing age. Now, closer to menopause, supposing the patient had undergone was menopausal at around 50. Now, for a year or two, she may still have functional cysts or endometriosis or even PID sometimes, but the incidence of these will decrease with the increase with advancing age. So we are talking about true differentials in a truly postmenopausal women. Things that will have to come to your mind are benign tumors. See, dermoids can occur in any age group. You can have the epithelial benign tumors, which are very common, serous and mucinous cystadenomas. Then you can have borderline tumors of these varieties. And of course, malignancies will always linger in your mind. You need to exclude malignancy first, be it epithelial, stromal, or even metastatic. But what you have to remember is that tuberculosis is a perennial disease in India. It's a national disease, and it comes in all age groups. It always has to come under your differential whenever you have a postmenopausal adnexal mass. So the clinical diagnosis of a complex ovarian mass is not easy. It's not straightforward. It's like putting a puzzle together. You need to take the history, you need to take examination, imaging, tumor markers, all of this you have to assimilate, and you have to try and put it together to at least arrive at a diagnosis. And a lot of times still your diagnosis may not be complete. So first, about history. As I told you, the age of the patient is important, because as age advances, some of these diagnoses will be excluded by default. The second is duration of complaints, because as like Subhitra Madam told, the duration, when you have a long-standing ovarian mass, the mass present for a longer time will enable itself to change in character. Like this lady, 55-year-old, she came to us with abdominal distension for 3 years. She came to us with a huge ovarian mass. Now, the thing is, like, there was no one to bring her. She came to us only when she couldn't lie down. So when you look at the imaging is very bland, very simple looking, no cyst, no septa, no solid components, nothing. The huge mass, 22 kgs. But even when you look at the cyst wall, very simple, no projections, no papillae, nothing was there. But then the biopsy report was mucinous microinvasive carcinoma. So the thing is, like, you'll have to remember that even, bland looking ovarian masses, if it is long-standing, you have to think in terms of a borderline or a malignant change. And as Madam rightly said, history of endometriosis. You always have to ask them history of endometriosis. These ladies, whenever you have an ovarian mass arising on top of an endometriosis, you always have to think in terms of a malignant transformation, though rare, but we do see a lot of cases. So you have to ask for history of laparoscopy previously, infertility and all. This lady, 50 years, she came to us with a large ovarian mass and with renal failure. She had bilateral ureteric obstruction and renal failure. Whenever you have a very large mass, endometriosis doesn't occur to like 28 weeks size. So large mass, or when you have solid and cystic solid areas within an endometrioma, especially with vascularity, always think in terms of a malignant transformation. And the malignant transformation generally is in either an endometrioid or a clear cell variety. Remember, this can occur even in the postmenopausal women. No known case of endometriosis, endometriosis getting dried up, and then still 65, 70, patient developing a mass, they can still develop an endometrioid or a clear cell cancer of the ovary. And then masses presenting with ovarian masses along with postmenopausal bleeding, always think in terms of a hormone secreting tumor. So this case, this is a granulosa cell tumor. You can see the endometrial hyperplasia present inside. But one thing you have to remember about a granulosa cell tumor is that it has got a varied imaging appearance. It can come from, usually you have a multiloculated cyst like this. a lot of times you have a solid and cystic mass, but then you can have just pure small solid masses, and you can also have very simple ovarian cyst-like picture also can occur in a granular cell tumor. So they have a very, very varied, gross appearance. And then about history, usually pelvic abscesses are not very common in the postmenopausal women. But then supposing that this patient had a history of diverticulosis, a known case of diverticulosis presenting to us with this kind of imaging, thick-walled septa with collection inside, very typical of a pelvic abscess. You can have CA125 elevation. Now, always think when you have a diverticulosis, you always think in terms of a pericolic abscess leading on to a pelvic abscess. So history becomes very, very important. And one thing that you have to remember is that any kind of ovarian mass which occurs in the background of a very strong family history, even a simple looking ovarian mass, you must rule out malignancy. So these are some of the things you have to remember in a history. And then moving on to examination, you need to do a thorough examination. Basically, when you examine the patient, there are two kinds of presentations you will end up with. One is like you can have a fixed uterus, with a POD mass, fixed uterus, or a nodularity. These are pointers towards an advanced ovarian malignancy, or sometimes a mass arising over an endometriosis. All of these can present with a fixed uterus, POD mass. Then you can have ascites and ovarian mass with peritoneal deposits. Again, pelvic deposits which you feel on rectal examination. Again, these are pointers towards an advanced ovarian presentation or a metastatic disease. The other spectrum is a mobile, large complex ovarian mass like picture. When you have an mobile mass, then your differentials will be a benign tumor or a borderline or a non-epithelial, stromal granulosa cell tumors, or even a stage 1 epithelial ovarian mass which is confined to the ovary can present to you with just a mobile mass or just a mass without any evidence of extra ovarian disease. So these are things that you will have to look into on examination. And this next, moving on to imaging. Now, the imaging of choice, when you have a localized kind of presentation, your first line investigation would be an ultrasound. And if your ultrasound is not indeterminate or not very conclusive, then MRI is the problem-solving tool. Now, if you have a clinically advanced presentation, like the pelvic deposits and all, ascites and all that, then you most probably are dealing with an advanced ovarian malignancy. So there, the imaging of choice would be a contrast CT abdomen and pelvis. Ideally, you need an IV and an oral contrast. So these are the two ways of presentation and your imaging modalities of choice. Next, we'll come back to imaging a little later. Then the last thing you have is a tumor markers. Now, in a postmenopausal woman, you don't have to do AFP. We still keep getting patients who have AFP, beta, HCG, LDH all being done postmenopausal. Not necessary. After 35 years, you generally do not have to do a germ cell marker. The markers which are done are CA125 and CEA. CA125, as you all know, is because it's an epithelial marker. CEA can be elevated in the mucinous tumors, but that is not the reason why you do a CEA. You do a CEA to rule out metastatic ovarian tumors. Basically, what you do is a CA125 by CEA ratio. Now, when this ratio is more than 25, then it points towards a primary ovarian malignancy. When your CA125 by CEA ratio is less than 25, then you have to rule out a metastatic disease, primary GI from somewhere else, then it is a metastatic tumor to the ovary. So this is the reason why you have to do a CEA. So the two important tumor markers you must do in a postmenopausal ovarian mass is a CA125 and a CEA levels. Now, as you all know, CA125 is not a very good marker. It has got a lot of false positives and false negatives as well. But in the postmenopausal women, it is generally a better marker because a lot of the conditions like fibroids generally become inactive, PID is not there, pregnancy is not there. So a lot of conditions are ruled out. So in a postmenopausal women, generally CA125 is a better marker. But then here again, you can have false negatives, meaning that the CA125 can be normal despite having malignancy in borderline tumors, in mucinous tumors, and in 50% of stage 1 epithelial ovarian cancers can have a normal CA125 value. So it's important that you remember that you cannot say that CA125 is normal, but it cannot be malignancy. So it doesn't happen. Then you can also have false positives in postmenopausal women. So we've seen case of torsion, tuberculosis, all of these can still have an elevated CA125 level. So it's not a very good marker. You have to remember that it's not a good diagnostic marker. It's definitely used in prognosis, but then it's not a very good diagnostic marker. A little better in a postmenopausal compared to a premenopausal women. Now this CA125 is by CEA ratio I was telling. This lady, 49 years old, she came to us with a large mobile abdominal mass. When you look at the imaging, see, very bland. No, just few septa and then nothing, no solid area, nothing. But the CA125 was normal 12, CEA was 34. The ratio is 0.3, less than 25. So you must have, you must think in terms of metastatic disease. This thing was overlooked, and during surgery we were called. And inside you can see that there was evidence of pseudomyxoma, and this was an appendicular primary. It was a low-grade mucinous carcinoma of the appendix with ovarian metastasis and pseudomyxoma. So always remember, whenever you have this kind of thing, you have to remember, because you will be caught unaware inside. You will have a problem during surgery. So there are several tools available for preoperative assessment. Now, how do you know? The problem is, like, you want to know if the mass is malignant or benign. Now, there are several tools, as you all know. The risk of malignancy indices 1 to 4. You have the ROMA, the IOTA index, ADNEX models. Then the new one is the ORAD. So several things are available. Now, a small example is the RMI. Now, this patient is particular. She is a premenopausal woman. Basically, she presented to us a not very large, 7-8 centimeter ovarian mass. One locule here, and this is a solid area. So this ultrasound, now just giving you an example, ultrasound score is 3. Her CA125 is normal. So for a premenopausal woman, the RMI is 105 only. So this is a negative, so means that it is, it is not malignant. But same condition, postmenopausal women, as RMI is 315, because you give a menopausal score, you give the value as 3. So this patient turned out to be a high-grade serous cancer. So RMI generally performs in a better way in a postmenopausal women. In a premenopausal, though, you really cannot go with RMI at all. Now about ORADs. ORADs is a good classification system. Now you have the ORADs ultrasound, and then you have the ORADs MRI as well. It is a good modality because it uses imaging only. Now ORADs 1 means it is a normal ovary, follicle or a corpus luteum. Now ORADs 2 is again all benign, classical benign lesion, typical dermoids, typical endometrium. When you put in, the Devi Meenal madam is here, she'll tell you that when you put the probe inside, you can tell that, okay, she's got a dermoid, she's got an endometriosis, simple paraovariances, all of these. The risk of malignancy is less than 1%. So ORADs 2, very, very reassuring. ORADs 3 is when the risk of malignancy is less than 10%. Here, little problems occur, little larger side, simple cyst, but quite large, more than 10 centimeter, or few locules and some color flow, smooth solid areas. Now, the risk of malignancy is there, less than 10%. The problem comes with ORADs 4 and 5. When you look at these, you see that the irregularity increases, the solid component increases, and vascularity increases. So as the size, the irregularity of the solid area and the vascularity increases, the risk of malignancy keeps increasing. In ORADs 5, the risk is more than 50%. So for whenever you have ORADs 3, 4, or 5, when you're not very sure, you could use MRI as a problem-solving tool, because it helps you differentiate when there's a blood clot or from a solid tissue, or you also have these enhancement patterns which can determine whether these are malignant. So the problem solving, if you're not sure in an ultrasound, then the next modality has to be an MRI and not a CT. So you have to choose the proper modality as per the presentation of the patient. So you have to, the imaging appearance. So it's important that you remember that these two are the most important imaging findings that you must not miss. The very, very high probability of malignancy, irrespective of tumor marker levels, is when you have solid lesions, solid cystic mass, and especially if there is profound vascularity. And of course, when you have ascites and peritoneal deposits as well. So these are two important imaging findings that you must not disregard. These are some examples. See, solid cystic mass with vascularity, all of these are high grade. This is high grade serous, this is low grade serous cancer. Now, whenever you have a mass like this, it's important that you will have to plan a laparotomy. You will have to do you have to be prepared for a full staging, and sometimes, you will have to do a cytoreduction as well. See, these small peritoneal deposits may be missed on imaging. You will land up to have an advanced disease. So actually, even in this kind of cases, it's a good practice to put in a laparoscope, see what you're dealing with, and then convert it into open surgery. Not complete the surgery by open, but then you can put in a scope, see what you're dealing with, and then always laparoscopy helps in that way. Now, this is a typical appearance of a borderline tumor. This is a mucinous tumor, multiple cystic, multiloculated cysts with varying sizes, very typical of this honeycombing appearance, very typical of borderline mucinous tumors. And these are typical appearances of borderline serous. These gritty papillary projections. When you have, these are appearances of borderline serous tumors. And remember, this borderline tumors, the final diagnosis is only after final histopathology, because you need to section every 2 to 2 millimeters. So that's not possible in a frozen section. But then, so you do have an error of 10%. But see, these kind of borderline imaging, you can get off with a limited staging, meaning that these do not require full lymph node dissection. So generally what we do in our hospital is like, if the picture is like this, I ask the unit people to open up, send it for frozen. So only when it comes, if it turns out to be malignant, I go. Otherwise, they do a hysterectomy, omentectomy, and appendectomy. So it generally, the procedure can be completed with that only. So this is the second imaging appearance, and this is one thing that you'll have to remember whenever you have a bilateral solid ovarian mass. Always think in terms of a metastatic tumor. And also, even if the mass is cystic, if the CA125 by CEA ratio is less than 25, you also have to think in terms of metastatic tumor, and you must do a complete GI and other evaluation. And in these conditions, you will have to do other tumor markers like CA99 as well. And then apart from this, you have other differentials in the postmenopausal women. See, it's not that fibroids do not occur. So this very, very bad looking ovarian mass, solid and cystic mass, just turned out to be a fibroid with cystic degeneration. Now, you can have these in the postmenopausal women as well. So that is why I told you, whenever you have a complex ovarian mass, you can put in a laparoscope, see what you're dealing with. Because if you know it's a fibroid, you can just do even these large fibroids, you do not maculate in the postmenopausal women. You can go by a transverse incision and remove the uterus. So that is the advantage of doing starting off with the laparoscopy. The other differentials are, of course, retroperitoneal masses. These can be picked up sometimes if you do not give importance, do not see the imaging well, you land up in surprises like this, retroperitoneal masses. Even today morning, we had one case, 12-year-old girl, presenting as an ovarian mass, and then it turned out to be a retroperitoneal presacral mass. So it can happen, retroperitoneal masses. And then pyometra, this was reported again as an adnexal mass, turned out to be just a pyometra. So these are all differential, and this is one thing that you always have to remember: tuberculosis. Now, 78-year-old woman presented with ascites, this peritoneal deposits, CA125 elevation, and then the omental biopsy was just granulomatous, and then after ATT she settled down. So these are all, and of course, whenever you have ascites and pleural effusion, solid ovarian mass, think in terms of Meek syndrome. So these are all the other differentials that you'll have to remember. So to conclude, what you'll have to remember is that whenever you have a solid mass or a solid cystic mass with vascularity, irrespective of the tumor marker levels. So, and then when you have ascites, peritoneal deposits, in a postmenopausal women, RMI is quite good. So more than 200, or whenever you have an ORAS more than 3, or when you have an ovarian masses with elevated CA125 in a postmenopausal women, then it's always better that you get help during surgery, because these kind of women may need full staging or even a cytoreduction. So this is what I prepared. Madam, do I have a few minutes? Maybe I'll talk about a little about screening if you want me to.
Yes.
Yeah, so ovarian cancer screening, basically, basically before you want to screen, you need to identify a lot of criteria has to be fulfilled. Now, one is like the disease obviously has to be a large, public health program. You should know the natural history of the disease, and then you should have a proper sensitive test which is available, and then you must be able to bring over to mortality reduction. So these are all some of the criteria which has to be fulfilled. Now, when you look at the ovarian cancer, we are not very sure of the pathogenesis, all very, very enigmatic disease, because it's a huge bag. It's not one disease like cervical cancer, it is a huge, mixed bag. The pathogenesis is not well understood. The tests available, CA125 and the ultrasound, are not so sensitive or specific. And then about the mortality reduction, there were 2 large-scale studies which were done, the PLCO and the UKC tox study, which included a very large amount of women. And they did this annual TVS. In a PLCO study, they did transvaginal scan and CA125. followed them up, and they did not even detect patients in the earlier stage. Now, all of them still they detected in advanced stage. So there was no stage migration, no mortality reduction. In the UK tox study, what they did is they used what is called the ROCA algorithm, wherein CA-125 was only used, and based on they used the level of CA-125 to triage next therapy, whether they're sending the patient for ultrasound or asking them for a shorter follow-up or a long-time follow-up. So it's called a ROCA algorithm depending upon the age group of the patient. So what happened in this study was they were able to pick up more stage 1 cancers, but again, mortality reduction was not there. So even when you do the screening, it doesn't translate into reduction in mortality. So ovarian cancer screening is not to be done for it doesn't work in a general population. Even for a high-risk population per se, it doesn't work well. The most important thing that you can offer to high-risk women, meaning those with BRCA positive, is like you can do a risk reduction salping oophorectomy. So that is the best thing that you can offer to them. For the general population, the best thing that you can offer is an opportunistic salpingectomy. So at the time of hysterectomy or during sterilization, what you can do is you can remove the entire tube. So then because tube is the source of high-grade serous cancer. So then that brings about a reduction in incidence of high-grade serous cancer, is something that we really do to bring down the incidence of high-grade serous cancers for these women. Thank you for your patient listening.
Thank you, Kavita. As usual, it was an excellent and a clear talk. I think you talked about how to evaluate postmenopausal adnexal mass and how the imaging studies, how you use the imaging studies. It was very excellent. It was an excellent talk, Kavita. Thank you very much.
Thank you.
I think we can move on to our next topic. Recent updates in endometrial cancer. This will be by Dr. Anbukani Subayan. She's a consultant oncologist and a robotic surgeon from Kovai Medical Center, Coimbatore. She's an editor oncology, European Journal of Obstetrics, Gynecology and Reproductive Biology, and a member representative of International Representative Council, South Zone RCOG. And of course, got a lot of fellowship awards from Australia and Portugal. Over to you, ma'am, for your talk on recent updates in endometrial cancer.
Thank you, ma'am, for that kind introduction. I feel like I'm amongst my teachers, a lot of seniors. I'm actually feeling like I'm going to write an exam or something like that. So please don't call me ma'am, because I'm sure we've all, I've been a student at least from near or far in front of many of you many years ago. And it's such an honor to be here with the Chennai Menopause Society to be giving this lecture. With the chairperson's permission, if I may please share my screen.
Yes, ma'am, you can share.
Just doing it right away. Okay. So I'm going to condense the updates in endometrial cancer, which is a very exciting phase to be in if you're dealing with oncology patients. And the thing is that in the last 2-3 years, there's just been a flurry of activity in endometrial cancer management. I will try my best to try and stick to my time, but kindly remind me if I'm overshooting, so I will stop wherever I am at that point in time. As we all know, endometrial cancer is considered a disease of the effluent, and this is steadily increasing even in so-called developing countries like ours, or middle socioeconomic countries or low socioeconomic countries like ours, because of the rapidly rising rates of obesity, diabetes, hypertension, added with women's choice to have lesser number of children, and the higher percentage of women who are now in the perimenopausal and postmenopausal age groups. This is not just a disease in the Western world. This is the actual data from Indian cities, particularly Bangalore, Chennai, Delhi, and Mumbai. And you will see right from the 80s up until now, which is not even now, but in the last decade, there has been a steady increase in the incidence of uterine cancer, And we expect that this number is going to just explode. As ma'am said, the WHO said that 1 in 3 will have cancer, but they've now changed their statement to 1 in 2 will have cancer at some point in their lifetime, presumably because we're living longer, we're diagnosing better, and also because of the explosion of socioeconomic factors. So our concerns when we treat any malignancy is obviously survival, but we also want to optimize treatment, make sure that the patient gets the right treatment, and at the same time avoid unnecessary interventions and therefore its resultant morbidity. And the same applies with endometrial cancer. We all know endometrial cancer presents almost always with abnormal uterine bleeding. About 80 to 90% will come with spotting or an abnormal blood-stained discharge, or with postmenopausal bleeding or AUB, and therefore we have to initiate the protocol that we usually follow in our clinics or hospitals for all PMB and AUB patients with high risk factors. Most of the presentation that I am going to be doing is from the NCCN and the ESCO guidelines, and this is just as a way of putting in my references so that if you need further reading, you might access this, which is free of charge on the internet. So this is the European Society of Gynaecological Guidelines and the NCCN guidelines, which sort of like the we refer to this all the time in oncology units. When a patient is presents with postmenopausal bleeding, the NCCN guidelines, ESCO, all of these guidelines suggest that transvaginal ultrasound be the initial investigation of choice, and that's what we all follow. Simply a cutoff of 4 mm is used in most units as the cutoff for considering interventions. So any woman with less than 4 mm cutoff is usually considered to be not harboring a malignancy, and we can keep her on follow-up. A woman with more than 4 mm or equal to 4 mm or any other high-risk factors should usually be offered an biopsy. And the standard low-cost effective biopsy is to do an outpatient temple biopsy. But of course, hysteroscopy is the gold standard, and nothing much has actually changed in this area. What has actually changed is, apart from this initial investigation of a transvaginal ultrasound and a biopsy, if you look at the NCCN guideline, it also says that at that point, we need to consider a genetic evaluation. Now, this has become the new change that we are going to look into in the next few slides. So this is the first initial evaluation. So while we did the ultrasound and we picked up a biopsy, the guidelines are automatically asking us to consider genetic evaluation at that point. And this is as soon as the patient presents, and that's a significant change in carcinoma endometrium management. Let's see that in a bit. I'm just going to go into what we do in terms of further imaging once we have that biopsy report saying a patient is diagnosed with endometrial cancer. We do the clinical evaluation for risk factors, comorbidities, and apart from that, we do a chest X-ray or a CT scan. We should also offer another 3-dimensional modality like an MRI or a CT scan. Now, an MRI is preferred. This is the first choice of investigation for an endometrial cancer assessment because it helps us to assess the tumor size, the myometrial invasion, whether it involves the cervix, as well as lymph node metastasis. As far as ultrasound and MRI are considered, they are almost equivalent in terms of diagnostic performance for detecting myometrial invasion. And therefore, as well as in cervical stromal invasion, therefore, if you have an expert sonographer, you might use an ultrasound to assess myometrium or to assess the cervix. But an MRI is the preferred modality for assessing the lymph nodes. The CT scan or PET-CT also has excellent specificity and for detecting lymph node metastasis. What one really chooses depends upon the affordability of the patient, access to these investigations, and finally, the physician's choice. In most centers, it's almost uniform now to do an MRI of the abdomen and pelvis because this covers almost all the parameters that we look into when we decide to plan therapy. There is no clear guidelines on when and what to choose, but I would say most guidelines would go along MRI as the first choice. Next, we come on to staging and risk assessment. Now, this is the area where a lot of exciting developments has happened because like the guest of honor said, we are now having molecular markers and targeted therapies in carcinoma endometrium, and we are starting to put that together very early on in evaluation as well as in management. Now, let us see where this all developed from, because we need to look to the future, but we need to learn from the past. So what happened in the evaluation of risk stratification is, over the last 50 years, we've moved from Bachmann's dualistic model to what we call as GOG criteria, to POTEC1 criteria, to a different histological classification that WHO came up in 2014, to ESMO, ESTRO guidelines for risk stratification. And now we are one step further. I'll talk about it in a minute. Now, this was Bachmann's dualistic model. They simply classified it into two types, type 1 and type 2, one being at one extreme of very well differentiated, good prognostic, slow to metastasize cancers, to the other high-grade, early to metastasize peritoneal mets and visceral mets with poor prognosis cancers. But things don't remain simple anymore. Beyond this, what happened was, this is in a picture, the ESMO guidelines, the ESMO risk group, the GOG 99 risk group, and the POTEC1 risk group. And as you can see, multiple factors developed. Most important factors were the type of cancers, whether they were endometrioid or non-endometrioid, the grade of the tumors, myometrial invasion, lymphovascular space invasion, lymph node invasion, and then metastasis. So based on this, these groups were classified, divided into low risk, low intermediate risk, high risk, and high intermediate risk, and high risk. I'm not even going to go into the details of this because we are not using this so much anymore. We've moved still further. This is what we are currently asked or recommended to use. So this is the classification that came up last year, the molecular classification and the risk stratification of patients into low intermediate, high intermediate, high and advanced metastatic disease. And for a person who's not familiar with the molecular classification, even for someone who's familiar with it, it is deeply confusing. So this is something that you may not be able to remember right across your brain, but you might have to have in front of you as a printout or on your computer, says as a screensaver, to keep going in and out. Let me tell you where this is coming from. Why did this all come up? Now, this was based on the realization that the endometrium is not a single entity. It's not just a tumor in the endometrial cavity and you do a hysterectomy and the treatment is done. But after the Cancer Genome Atlas project, which basically looked into all the genes and mapped the human genes under the Human Genomic Project, the Cancer Genome Atlas project looked at cancer genes linked to cancers in different sites. Based on that, they realized that endometrial cancer, out of all the cancers that we know in the gynecological tract, is a heterogeneous group with variable risk and prognosis. Putting it all together, what they classified this group into was 4. One was the one called pole mutation positive group, which is women with endometrial cancer who test for this particular mutation, which is called polymerase epsilon mutation. When they test positive, they are grouped into the pole mutation group. Then you've got the MMR deficient group. Now, MMR is the mismatch repair gene deficient group. Commonly, we can scratch our memory and we would remember that MMR group is the one that is associated with the Lynch syndrome. Then you've got the copy number high and the copy number low. What are these groups? Again, the molecular classification ranges from the pole ultra-mutated, MSI hypermutated, copy number low, and the copy number high. And the genomic burden is highest with the pole, drops down to the copy number high group. But the prognosis is poorest for the copy number high group, which is basically marked by the P53 mutation. So we've got more markers now for 3 of these groups, the pole, which can be done as a genetic test like we do the BRCA test. We've got the MSI. Again, we've got 4 genes here, which can be done as a genetic test. But luckily, we also have IHC markers for the same MSI mutations. Copy number low, which is one group where if you're negative for all the other groups, you're just bulked into this particular group. And copy number high, which is marked by the P53, which can again be tested genetically or can be done on the IHC, which is just on your slides and plots. So how does this translate clinically? Clinically, there are certain guidelines on how to test. Basically, you can just send them off completely as a panel, IHC panel. Most units do that. So they test for poly, they do the MSI or the MMR mutations, and they test for P53. So it's a set of about 6, along with the ER, PR if needed. ER is usually done, which is the estrogen receptor test. But some guidelines say that you could do it in a stepwise manner, where you test first for the MMR genes, and then you test for the pole mutations, and then you test for the P53. The idea is that these have certain importance. There are people who will test for 2 genes at the same time. So what happens then? We have separate guidelines for that as well. For example, if pole is mutated and P53 is mutated, we treat them as pole mutations with excellent prognosis. Now, to cut the story short, what are the clinical implications of these 4 molecular groups? Less treatment in good prognosis group. So less treatment in the pole mutation group. If pole mutation is positive, the patient gets substaged now based on the new staging, and you do not have to give them chemotherapy or radiation therapy. You can plan adjuvant treatment in copy number high group, which is the extreme right group from my previous slides, which is the P53 group, provided all the other mutations are negative, because these have worse prognosis. You can plan treatment in fertility sparing setting. If you do the mutation testing at the time of presentation, you might sometimes not put patients on medical management if they are fertility patients coming in with an endometrial cancer and they wish for medical management. You might have to talk to them about the worst prognosis type of cancer that they are harboring if they test positive for P53. Similarly, the MSI group or the Lynch group, which also has a higher propensity for ovarian and bowel cancers, may also be appropriately worked up, counseled, screening protocols put in place. And finally, now we have targeted therapies in advanced and recurrent setting of endometrial cancer. Now, as far as targeted therapy is concerned, I'll just finish it right here that this is a miracle molecule that has recently got FDA approval for endometrial cancer. It's a PD-L1 molecule, pembrolizumab. It is now found useful for patients with microsatellite instability, the second group, which has got an intermediate prognosis. And studies have shown that there is reliable response to this molecule with better progression-free survival and potentially better overall survival. And that's the therapeutic implication of testing for molecular markers. Now, that's one part of it. Let's come back to where we started, which is, what do you do when you have an endometrial cancer? Have things changed there? So we all find 70% of the patients that have uterine cancer present in stage 1. So most of them will automatically qualify for surgery. That is the default option our patients will usually be offered. And the surgery that we know is also total hysterectomy and bilateral salpingo-oophorectomy with surgical staging, unless the patient is not suitable for a surgical option. So this is the default setting. What is the mode of surgery? Has there been any change in that? Yes, there has been. Most of these endometrial cancer patients are comorbid rich. They are diabetic, they're hypertensive, they are obese, and now they're also morbidly obese with the pandemic of obesity now. And therefore, when you offer a hysterectomy with BSO, it is recommended that you offer it by the minimally invasive route so that we can reduce the operative morbidity for these patients. And if MIS is not available, because India is a vastly varied medical settings country, and therefore it's not available, then the second option is a laparotomy. But if options are available in big cities, in tier 2 cities, then minimal invasive surgery is the recommended approach, and this is out of the NCCN guideline. It is now it is proven to be safe. It is proven to have equivalent outcomes compared to the gold standard of an open laparotomy, and therefore this is the recommendation. It can also be considered in all kinds of risks, the intermediates, the low and the high risks that I put up, provided the team is suitably trained. In a small subgroup of patients, we can consider vaginal hysterectomy as well. While minimal invasive surgery is recommended, it needs to be remembered that we have to avoid intraperitoneal tumor spillage. Therefore, morcellation should be avoided. You cannot morcellate even inside a bag because we want to know what the myometrial invasion is. And if there is vaginal extraction, you have to make sure, if you think that the uterus is going to rupture because it's a fairly large uterus, you might have to opt for a mini laparotomy. There's no point pushing and pulling this uterus from below and rupturing and spilling the tumor. If there is tumor outside the uterus, it's a relative contraindication for minimally invasive surgery. Now, as far as stage 2 is concerned, why I put up the slide is this consistent question that if it is stage 2, it involves the cervix, and therefore, do you have to do a radical hysterectomy? A radical hysterectomy is not required for an endometrial cancer involving the cervix unless you do not get margins. In the sense, if it's already coming out through the cervical stroma and involving the parametrium, then you have to make sure you don't cut through the tumor, and therefore you might have to do a radical hysterectomy. But for a tumor confined within the cervix, just a total hysterectomy is what is recommended. Now let's come to the other big part where there has been a lot of updates, which is the lymph node staging. Now, stage 1 and stage 2, we saw that it is hysterectomy with BSO, preferably minimal access, and then surgical staging. Now we're coming to that part of the surgical management. So far, we know that stage 3 is classified into C1 and C2 depending upon whether pelvic nodes are involved and para-aortic nodes are involved or not. Therefore, the simplistic reason why we need to do a lymph node staging is because we want to know what the stage is. So when we used to do a hysterectomy and BSO and just send the patient off for further management, that automatically qualifies as an incompletely staged patient. We cannot do that anymore for any endometrial cancer patient because lymph node staging is now part of endometrial cancer staging. It comes as stage 3, it's further stage 3C, and it's then divided into C1 and C2 depending on which group of nodes are involved. What is the current concept about lymph node sampling? That has also changed, and now it becomes lesser is better because the risk factors have modified from the 80s to 2010s. What we used to do as a big midline laparotomy and do the entire pelvic and para-aortic lymph node has now moved into sentinel lymph node mapping. What is sentinel lymph node mapping? Where did this come from? This came out of a huge trial, which is called the FIRES trial, which is the fluorescence imaging for robotic and endometrial sentinel lymph node biopsy trial, which showed that sentinel lymph nodes could be successfully mapped in endometrial cancer patients with very high sensitivity and negative predictive value, which basically means that compared to patients who had pelvic lymph nodes, if you just remove the sentinel lymph nodes, it had the same kind of sensitivity in picking up lymph node positive cancers. This was a major shift, a step towards a paradigm shift in surgical staging. High-risk cancers were also tested, and sentinel lymph node detection was proved to be safe and efficacious in high-risk endometrial cancer patients as well. But what is sentinel lymph node mapping? Sentinel lymph node is basically the first node that comes from any organ. Whether it's the breast, whether it's the vulva, whether it's the uterus, you will have the first node, the lymphatic from that organ going into a first node, and then it goes like an arborization pattern into the nodes upstream. Now, detecting that first node is called sentinel lymph node mapping. That node could be anywhere. For the uterus, it could be the obturator node, it could be the external iliac node, it could be the internal iliac node, or it could even be the para-aortic node in that particular patient. So how do we know which is the first node? We need to do this in real time. We inject the dye into the cervix prior to incision. we use a dye called indocyanine green. That's the commonest dye that's used now. But earlier they were using methylene blue, and we could use technetium 99. And you open up the patient and you expose the entire nodal basin. You're not doing the node dissection, but you're opening up the pararectal, the paravesical spaces and the paraiotic spaces. You're viewing it with a special camera, and you're actually seeing the dye flowing out of the organ to that first node. So the person who's doing the nodal procedure needs to know what the standard draining pathway from that organ is, and should be able to track with their eyes where the dye is flowing and what are the nodal basins that you need to be looking out for. What does it look like in real time? This is what it looks like. So you will have the node light up like this. And this is the indocyanine green. Therefore, when we put on, it's like a laparoscopic camera, but when you turn on a switch in the laparoscopic system, the whole screen becomes gray and only the dye is seen as green. And from the point of cervical injection, you can see it traverse through these small blood vessels and enter into the node. And that particular first node is taken out. So if you do it too soon, you will miss the node. If you do it too late, you inject the dye and you take 20-30 minutes to open up, all the nodes will light up. So accuracy depends on how you standardize the procedure in your particular unit. Therefore, the NCCN recommends that each center should do about 20 to 30 cases before they iron out all these problems, and they know exactly when they're injecting, how long their port placement takes, how long their laparotomy takes, how much dye to inject. Are you okay to, are you experienced in opening up the fields before the dye flows? All of these needs to be standardized. So there is a checklist that cancer centers follow. Apart from removing the node, it doesn't stop there. Your lab also needs to standardize the procedure. They don't do a simple histopathological examination. They do something known as ultra staging. So this is what sentinel lymph node staging is. This is considered now gold standard in centers which have standardized their procedures. And it can be considered for all kinds of endometrial cancer patients in which there is no enlarged lymph node, radiologically enlarged lymph node on the MRI. Therefore, your patient selection is also important. It's uterus confined disease. In case you're not able to pick up the lymph nodes because the lymph node's already enlarged or something is blocking the lymphatic drain, the lymphatic channel, then you have to still be trained to do a site-specific lymphadenectomy. And like I already said, ultra staging is recommended. If you don't have this, if you're not trained to do this, like I don't do sentinel lymph node staging because I do robotic surgery and my robotic surgery does not have the sentinel arm and my lab has, so I'm still kind of figuring out what to do. So I still don't do it. But if I don't do it, then I should be able to do the retroperitoneal lymph node dissection right up to the renal veins. Whether it actually helps in improving patient survival, it's questionable. It helps us to stage, prognosticate, and plan treatment. You need to be able to do it laparoscopically or robotically. And that's the most important thing with retroperitoneal lymph node dissection. Do you need to do omental staging? Only in a small proportion of cases with serous endometrial carcinomas or carcinosarcomas or undifferentiated carcinomas. Not all patients require omental staging. We can preserve ovaries now. The NCCN says it's a grade 4A recommendation that you could consider ovarian preservation in premenopausal women less than 45 years of age in very early disease, which is your low-grade endometrioid, less than 50% myometrial invasion. Regardless of ovarian preservation, even if you preserve ovaries, we need to remove the tubes because we know high-grade serous carcinomas originate in the distal part of the tubes as stick lesions. Therefore, tubes need to be removed. We cannot consider ovarian preservation if the mutation profile has been mapped. In BRCA mutation or in MSI, which is Lynch syndrome, you need to remove the ovaries. Now, as far as stage 3 and 4 are considered, cytoreduction needs to be offered. And this is what the guideline says, that if it's possible to debulk, surgical debulking, just like CA ovary, may be considered, and that is followed by adjuvant therapy. Now, this is regarding the surgical management. It's stage 1, stage 2. You know a little bit about the lymph node mapping. You know that in advanced cases, we do cytoreductive surgery. After all this is done, what we do is, depending upon the final histopathology, we had mapped them as low risk, intermediate risk, high intermediate, and high risk. This was to offer adjuvant therapy. So if it was low risk, it was just follow-up. If it was intermediate risk, depending upon the cases, just brachytherapy. I've simplified this to a large extent. This is not the rule, but this is just a rough guideline. High intermediate was brachytherapy plus external radiation, and high risk is chemotherapy. Now, all of this is decided by an MDT or a multidisciplinary tumor board. This has changed dramatically now. What used to be just this simple column on the left has now become this massive column with integration of pole markers and MMR mutations as well as P53 abnormalities. And for each case, if we are now starting to do molecular markers for every patient, unless they cannot afford it. And then if the molecular classification is known, the column on the right is the new classification of low, intermediate, and high risk groups. And as you can see, this is very new, and even oncology centers are struggling with it. And to add more complexity to the management of carcinoma endometrium, this is the latest. This was published in August 2023, a couple of months back, in the International Journal of Gynecology and Obstetrics. And this is the latest FIGO staging of endometrial cancer. And this has become hugely complex as well. If you can see, stage 1 is now classified as 1A, B, and C, and 1A is classified as A1, A2, and A3. Stage 2 is again into 3 subgroups. Stage 3 has become super complex in terms of metastasis to the lymph nodes, metastasis, micrometastasis, and macrometastasis. And stage 4 has been divided into A, B, and C. Molecular staging has been added to the FIGO staging as well. And pole mutations and P53 are now integrated into the staging in centers which can start molecular markers. So I'm not going into the details of this because it's hugely confusing even for us. It's very new. We do not know how we are going to do this in a country like India where there's huge economic burden for the patients. But this is what FIGO is recommending across all countries, low, middle, and high socioeconomic. There's been a lot of discussion and debates about this. Even countries like the US and UK have conducted polls among their doctors, and it seems that this is very difficult even in countries like those. But if you're following FIGO is the basic staging. We all follow FIGO staging. So if we have to stage them according to FIGO, this is what we are now being asked to follow. So to summarize, we know that it's on the rise. Endometrial cancers are no longer just a simple biopsy and a hysterectomy case. I strongly urge people who are managing these cases as a single person to start referring these cases to a multidisciplinary team. And we, even though it's surgical, now the recommendations are that we do minimal invasive surgery. The recommendation is that we opt for a sentinel node procedure. We offer molecular profiling high up in the initial evaluation itself. And if that's not possible, then we need to do that on the final histopathology of the uterus. And this is likely that there'll be a huge impact in the way we offer surgeries, fertility preservation, as well as adjuvant therapies. It's going to be a very confusing time for us, but I think in the next couple of years, endometrial cancer management is going to turn upside down. It is going to finally be the time of personalized medicine. This is just to summarize the recent updates in endometrial cancer, and I'm happy to take any questions. Thank you.
Thank you so much, Dr. Anbu. Such a wonderful and nice presentation at this younger age. And surely you must have been our students only. I'm just thinking like that. And so much of advances have come in endometrial carcinoma, especially the molecular markers. And
Yes,
more for recent advances, the postgraduate has to update themselves. So it's a very nice presentation. I'm sure there'll be a lot of questions. Thank you.
Yes, ma'am. Thank you. I'm an RSRM product. Just
Okay. Shanti ma'am.
Yeah.
Thank you. Thank you, Dr. Anbu. Excellent. And as usual, crystal clear. Thank you, both the speakers. And we will now proceed to our quiz, which is based on the talks. Sahiti? No, not this one. Sahiti, can we have the quiz? Yeah. We will display the questions. Audience, please answer, and then we will display the answers as well later on.
Five more
Can we
seconds.
move to the next question?
Yes, ma'am. Time up.
Yeah.
So second question. Last 5 seconds. Time up. Third question.
Is that
5 more seconds. Time up. Fourth question. Five more seconds. Time up. Fifth question and last question. Five more seconds. Time up. Thank you all the delegates for the active participation.
Thank you. Sahiti? Can we now invite the chairperson for our panel, Dr. Shanti Madam? Can you project the slide for her CV? We now welcome our chairperson for the panel, Dr. Shanti, Professor, Government Kilpatrick Medical College, Certified Trainer in Microsurgery, and faculty in various Oxy conferences, organizer for cesarean workshop, and organized many workshops and has more than 10 publications to her credit. Welcome, madam. May I request you to kindly invite the moderator and the panelists.
Thank you, madam, for the introduction and the opportunity to chair this session. Postmenopausal bleed is a common complaint for which the elderly women usually seek medical help. Both the clinician and the patient are usually worried whether it is malignancy. In the panel on postmenopausal bleed, Dr. Anbukani Subbayan, the moderator, and her eminent panelist will enlighten us about the management of postmenopausal bleed. Over to you, Dr. Anbukani.
Thank you, ma'am. So thank you again for this opportunity. I hope to give you some clear take-home messages with the help of my very eminent panelists, my teacher, Dr. Jayashree Gajraj, my friend, Dr. Kavita, who's a gynae oncologist. We have Dr. Nitya Sridharan, who's a medical oncologist. Nitya, I apologize in advance. I don't have too many questions for you, considering we are going to be looking into the various causes of postmenopausal bleeding, but there will be some key take-home messages that you will need to be giving here. And Dr. Devi, who's the head of radiology at KMC. So I look forward to the next 45 minutes for a feisty and a very active panel. If I may please share my screen. There's some echoing.
One, we will see. Anbar, please continue.
Yes, ma'am. Yes, ma'am. I'm on it. I think my previous presentation is still on here. Okay. So to set the stage, I'm going to first ask, what is postmenopausal bleeding? Can one of the panelists, ma'am, Jayashree ma'am, simple basic question. What is postmenopausal bleeding? So how do we define postmenopausal bleeding? Just to set the stage so that we can take off from here.
I think we'll have to define menopause as 12 months or 1 year from the last period. It qualifies for any bleeding that comes about after 1 year after cessation of the periods.
Is there any confusion? Earlier, we used to say
sometimes
6
people
months,
ask
6 months, and should we initiate investigations at 6 months? And should we just consider it as an okay period to have if it's after 6 months?
We may still initiate investigations. There's no doubt about it.
Ma'am, your voice is breaking. I'm not sure if it's your connection or mine, but is everybody able to hear Dr. Jayashree?
I think it's madam's connection.
Kavita, do you want to take that?
Yes.
Basically, this is for definition purpose. So the 1 year of amenorrhea, and as you've put it on the slide, the patient is not on any HRT, but then we may choose to investigate the patient at different, if she's a high risk, and then, she comes after bleeding, even after 6 months of amenorrhea, then you may start initiating treatment. But then the definition of postmenopausal bleeding is like any degree of bleeding when the patient is not on any HRT after 12 months of amenorrhea and the perimenopausal period would define a postmenopausal bleeding.
So since this is a menopause society meeting, I mean, do we have many patients on estrogen and progesterone now in the menopausal age group? With the destruction of the WHI data and the number of people that have been persistently pulling it down, are we starting an increase in the uptake of HRT? So if women are on HRT, should there be a different criteria? What is your personal experience on this, ma'am, Jayshree, ma'am?
Yes, certainly the number of people for whom we are prescribing MHT is increasing. I think the WHI data is slowly going back and we are certainly coming forward and prescribing, but the first line is still the local treatment with vaginal, etc. So the oral preparations are used for short term only. We do not use long term oral preparations. And the other routes like transdermal, etc. are not popularly used in India. So when the woman is on MHT, then we need to consider that, for example, when you're investigating, when you're looking at an ultrasound report or etiology in the endometrium, we need to keep that in mind. But if she's still perimenopausal, that's a different issue. But if she is clearly postmenopausal and she is on MHT, then the cutoffs will vary. We would not use the usual 4 millimeter cutoff. We would permit anything up to even 7 to 8 millimeters on a transvaginal scan.
Yeah.
But it depends on the pattern of bleeding again. It's not just the, if it's still irregular bleeding, postcoital bleeding, any of these, we have to take consideration for all that.
Yeah. So I think basically I put this slide up because we are going to see an upswing in the number of women who are going to go on HRT, because I think it's starting to see a swing back because of a lot of criticism about the WHI data and the abrupt manner in which HRT is dropped off like a hot potato. And in case the women are on continuous estrogen, progesterone hormone therapy, we expect some sort of irregular bleeding in the first 6 months, but this should cease after 1 year. And if they are on cyclical progesterone, then they have regular withdrawal bleeding after stopping progesterone. Therefore, for any woman who's on continuous estrogen progesterone therapy, the bleeding, any bleeding that occurs after 1 year of HRT should be investigated as well. So that's basically setting the stage. So I'm going to quickly go through what the common causes are. And then what I will do is I will go through how we manage each of those causes in order for us to have certain take-home messages. Some of the common causes for which bleeding occurs in a postmenopausal women are polyps in about 1/3, atrophic endometrium in another third. There could still be some amount of estrogen activity, which can lead on to a proliferative endometrium. And then comes your carcinomas. I'm not going to touch upon cervix, vaginal, or ovarian malignancies, but touch a little bit upon the uterine malignancies. Fibroids can occasionally cause bleeding, hyperplasias, and rarely medications. They could become commoner with HRT in the future. Now let's go into this bit by bit. As far as endometrial polyps are concerned, the incidence varies with age, and these are typically estrogen sensitive. They do have estrogen receptors on their surface, and therefore their incidence declines after menopause. They are the commonest cause of bleeding for women who are on tamoxifen, but rarely they can undergo malignant change into a carcinoma or sarcoma. So coming to how do you diagnose a polyp? We all know that just in my last lecture, I said when you have a postmenopausal bleeding, the first choice of investigation is a TVS. And when there is a 4 mm or greater endometrial thickness, then we start investigating. Can we diagnose polyps straight away? Can I have Devi ma'am on this?
Yes.
How do you diagnose polyps?
Actually, even though the patient is sent for the transvaginal ultrasound, we always start with the transabdominal ultrasound. So we don't want to miss the bigger lesions. That's the this thing. Because in the transvaginal ultrasound, the focal area covered is only towards the this thing. If it is going to be a bigger uterus, then you will not cover it. So first to start with the transabdominal ultrasound, and then have an idea, and then ask the patient to empty the bladder, and then go for the transvaginal ultrasound.
Got it.
Proper fanning, that is important. That is when you're moving the probe, you have to fan the entire endometrium or the uterus. Then only you can catch the lesions.
And so if it's a large uterus, would you take the endometrial thickness through the abdominal image or through the vaginal image?
If vaginal, you can't reach it. So you have to take it only in the abdominal images. So that's why you should ask the patient to come with the full bladder. That's very important. And you have a cervical elongation happening with all the cases of the LSCS. So in those cases also you need the abdominal images. But you can't go just with the abdominal images alone, because sometimes in the abdominal images you will see something looking like as if a pedicle flow in the color flow. But that's not the real pedicle flow. Actually, what you see is the bleeding which is happening. That streak can produce something in the color artifact which can also look like a pedicle flow. So you have to fan the image exactly. Is that is going into the lesion, and is it a true pedicle flow or this thing? Then after doing the abdomen, see, you have projected a nice transvaginal image. Yeah. In this case, what will I do is, see, this is nicely taken image. So it shows all the findings. Said, actually, you have to look at the interruption of the endometrial lining. So that's the missing of the lining, this echogenic line. So there is an interruption happening at this level. There is a lesion. So this lesion is projecting into the endometrium. So when you see this, you will think, is it a fibroid, a submucosal fibroid, or a polyp? Then you can look at it. See, if I am going to say this is a polyp, then I will say this is a polyp which has invaded part of the endometrium. So that becomes something as if like an endometrial carcinoma over here. Less than 50% of the myometrium is involved. So that is
for want of time, for the students or for the young gynecologists, what are the two markers or two important findings that
you find a lion-like, echogenic lion-like in the endometrium. Actually, if you find one or two lines, then you will think there's something there. Then you do a fanning properly, then you can see a focal thickening. So you have to look at the entire endometrium. There will be a difference. So there is a focal thickening, then you suspect a polyp.
Do these signs have any
echogenicity? Yeah, it's the interrupted mucosa sign which you have seen in that image also.
Yes.
Previous image also. See, look at this. There's an interruption at this level. Yeah. So can you see my? I don't think that you can see my. You can show that area. Yeah, that monitor area, right? So there is, but it has produced an invasion into the myometrium here. Yeah, but
what is the bridge? What is the bright edge sign?
That is the margins. Actually, the pedicle margin and the margins of the surface of the endometrium can be seen like that, actually. And the third point is you switch on the color, then look for the pedicle flow. So interruption of the mucosa, there is a focal thickening, and then you can even look at the multiple echogenic lines, and then pedicle flow. All the four will help you to come to an possible polyp.
Conclusion. Got it. So, but do you routinely, if you suspect a polyp, do you put in did you put in saline or do you turn on your 3D?
No, no need of saline at this moment. So, because you can make a wonderful 3D, even multiple polyps can be picked up in the 3D, and we can give exact for you to biopsy. We can give the exact measurements. These many millimeters from the external os in the posterior wall. So I can even say from the right lateral wall, this area you have to go and take it. And this is so much from the fundal endometrial cavity like that. So you need not miss it. Even if you're doing a blind pipetting, in that also, when you take this into account, you can exactly get these samples. But
no, I
guess of the cases being followed up.
So with a
polyp, kind of the polyps are only benign. It's not malignant.
That's true. So when we automatically as gynecologists, when we see polyps, I think we are thinking hysteroscopy. Ma'am, would you agree with that, or would you still go in for a pipple biopsy? Jayashree, ma'am? Jayashree, ma'am?
We are not hearing you, ma'am. You have to unmute, ma'am.
Yeah. Absolutely no role for anything else but a hysteroscopy.
Hysteroscopy, yes, I guess. So
Can
would
you
agree
hear
with
me?
that? Yes, ma'am. Now we can hear you.
So absolutely, you have to go for a hysteroscopy. It's a gold standard. Blind biopsy is only when you have a uniform thickening of the endometrium. If a polyp is reported or suspected, then there is no role for a pipple biopsy. Pipples will not sample polyps.
Absolutely. So that's set straight. So we do, just to put it in a nutshell, we can identify it based on these signs that we just mentioned, that ma'am explained. And the second point is you can turn on your 3D ultrasound and you can precisely identify where these polyps are located. And the third take home is if you see a polyp, there is no role for a pipple biopsy. You will miss it. They do not get pulled off the endometrial cervix into your pipple biopsy cannula. And therefore, you need to put in a hysteroscope so that you can do a direct visualization and remove it. And you should always send it for a pathological assessment. I'm sure we'll all agree on that.
Anbu, can I just add one point?
Please do, ma'am. Please do.
Sometimes the scan need not necessarily report a polyp.
Yes.
You may just tried an endometrial biopsy with using a probate or a pipple. When you don't get a proper sample, which is not consistent with the thickness that's reported on scan, again, you have to suspect a polyp.
Got it. So, ma'am, what percentage of polyps can we miss on an ultrasound?
It really depends on the operator. That is the this thing. So the experienced person can pick up more than 95% of the polyps. But even I do have come across few, like when, as madam said, it's the total endometrium is filled with very big polyp. Then you will report a 22 millimeter thickness of the endometrium. And from the fundus, the total length is full of
polyps. Yeah.
So
I think
that is a
the
single
data point
polyp
is
which
that
is there in the total this thing. Then there is no echogenic line anywhere. It's so totally this thing. And you don't find an pedicle also. That kind of these sessile large polyps can be missed.
So the thing with polyps is that they are benign, and therefore I think the risk to patient's life is probably less. But it's more important, like Jayashree ma'am said, to be focused on the symptoms of the patient. And if there's persistent symptoms, then disregard what the ultrasound says and still go in for repeated biopsies or for a hysteroscopy so that you can directly visualize. And I think that's a good take-home point. Now, atrophic endometrium, why should it cause bleeding in the first place? Atrophic endometrium is usually because these surfaces contain very little fluid, unlike the menstrual fluid or the gland secretion that happens during the premenopausal age group. There's very little fluid to prevent intracavitary friction, and therefore microabrasions happen and a chronic endometritis can happen. And literally these patients usually present with very light spotting or bleeding. Treatment is estrogen replacement therapy. And if the uterus is obviously still in place, you have to add progesterone. And there is no point of giving only estrogens for long term. So ma'am, how do you usually treat atrophic endometrium? What is the route of estrogen that you give? How long do you treat? How do you follow up these patients? Jayashree ma'am?
Yeah, to begin with, I think a word of caution, a diagnosis of atrophic endometrium has to be made only by exclusion. You have to make sure that you've excluded every other cause of, postmenopausal bleeding. We should not small 3 or 4 millimeter, pathology. If it's missed and the rest of it is reported as atrophic, we should be careful. So that's important. Secondly, if we are very sure it is only atrophic, then estrogen is the mode of treatment.
How do you usually prescribe it? I mean, what's your protocol?
When we're thinking of atrophic endometrium as a cause, I would still first go for a vaginal application of estrogen, because there is some amount of estrogen being absorbed even when you do a vaginal application. maybe keep her symptoms in mind. And if there is absolutely no reprieve, even after about a month or two of treatment, then with a lot of counseling, I would put her on the oral MHT combination, the estrogen and progesterone combination. But careful to bring her back often for review and repeat ultrasound. We have to be careful.
Got it. So,
can I just ask a thing? See, atrophic endometriosis, no, I think that can you just leave her alone without starting on the first episode of bleeding? Can you just keep her on observation? Rather
I believe
than
that would be the first choice, no, Kavita. I mean, that's what I usually do. I usually look at how much is the patient distressed. If it's just one drop of bleeding there and they come running to your OP for an evaluation and you see that the endometrium is thin, it's 3 mm, and you reassure them and say, okay, because less than 4 mm, we are not going to biopsy. So the commonest thing that I am thinking is this is an atrophic endometrium. So then you have this conversation of, are you really distressed about it? If it's just a spot, can we just wait and watch and not treat? I think no treatment is probably the first option. And if you go ahead, say it's a 5 or 6 mm, it can still be an atrophic endometrium, but it's just on the higher side for you to have biopsied it and still have that conversation and say, do you really need treatment for atrophic? I don't think at this point anybody is going to start. Once it starts distressing the patient, or if it's a supremely well-informed patient who might want to start HRT to stop the bleeding completely, because I think with HRT, you're starting a new set of problems. Then she's probably going to have regular bleeding. She's going to have the breakthrough bleeding and all of that. So I think it's very important to counsel them about that. So it's a nuanced conversation. The first option is, of course, no treatment at all, because these bleeds tend to be very minor. They tend to be just spotting. But if the patient is well informed, likely to come for regular follow-up, then there is no harm in putting them on HRT. Now, we always used to think of HRT as like, no, breast cancer. But that's, I think, out now. We are more open to treating them if they feel distressed with this problem. And I think that's a reasonable approach to these patients.
Often these patients, it's also associated with atrophic vaginitis.
Exactly. Yes.
And these patients do come with dryness and dyspareunia, etc. So we need to address it. It's
yes,
very
a holistic approach.
With isolated atrophic endometrium and then spotting where it is usually associated. So treatment will be required, but it is not a per se indication for MHT.
Yes. So first obvious choice is no treatment. Have a proper conversation. You do not have to be scared of hormone replacement therapy. If it is having multiple consequences like vaginitis and dyspareunia and persistent bleeding and patient is distressed, there's no harm in putting them on estrogen and progesterone. Local is better. Oral is a second option there. Can fibroids cause bleeding? Kavita, do you see these cases with postmenopausal fibroids? I almost have not seen more fibroids in postmenopausal setting, but do you have any experience with this?
Yes, we do see first 2 or 3 years following menopause. We do see, and some of the fibroids actually we've seen, some of them can do increase in size after menopause. We've seen cases, we suspect sarcomas based on that, but then final histopathology turns out to be fibroids. So we do see patients with fibroids in the postmenopausal women, but of course, you always have to have sarcomas in the back of your mind. So that's one thing, and you treat them like that because you do not morcellate, you remove in toto, no screw, nothing. Generally itself, we do not put screw and all that. But I'm just telling you that you treat them like a sarcoma, but then we do see cases of fibroids in the postmenopausal women.
So most important take home is if you see postmenopausal bleeding and the fibroids, it must be if there is postmenopausal bleeding and you see incidentally you diagnose a fibroid, do not attribute it to the fibroid. You must still rule out an endometrial cavity pathology. It could be a hyperplasia or an atrophy. And but importantly, if you see that the fibroid is vascular, you must at least think of a uterine sarcoma. There's no way to rule it out because MRIs are not very sensitive in ruling out uterine sarcomas. But you might want to think that maybe this fibroid is acting up and potentially on its way to a sarcomatous change. Typically, these patients will present with increasing size. There can be pain. And also there's some data that about 40 to 50% of uterine sarcomas, when you biopsy them, you might be able to get a diagnosis on the endometrial biopsy. That's also something that we need to keep in mind. what medications can cause PMB? I'm going to skip this because there's a whole bunch of medications that are put up in guidelines. Most commonly, what we see is older age patients who are on anticoagulants and antiplatelet agents. Therefore, thorough history along with what they are taking, what they are consuming is important, because at the end of all the search, it could just be some warfarin or something that they are taking. So coming to
just one point to add here, Anbu, if I may. Unopposed estrogen is still being prescribed by some of our colleagues in other specialties. So we need to ask for history of this also.
So where do you commonly see which group of patients, just for us to keep a reminder?
Postmenopausal, especially when they've had a fracture, etc., and they go, or just with a DEXA report, they go. Some of them are prescribed even today unopposed estrogen.
Wow. Okay. So good point to keep in mind. If you see patients coming from your orthopedic colleagues, please ask for, or your endocrinology colleagues had a DEXA scan, please ask for estrogen replacement therapy. So coming to what we all love to do is our ultrasound, and then what do we do for the biopsy? So just imagine that a patient has come in and she's got an 8 mm thickness on her transvaginal ultrasound. Why this 4 mm thickness, and what would be the investigation of choice further from that? Kavita, do you want to take this question?
Yeah, so see, as you've already mentioned, if you have a global, endometrial thickening, the first line investigation would be an office endometrial biopsy. So because your pickup rates are quite high, even if the sampling of the total endometrial cavity may be less, but then the pickup rates of endometrial pathology is quite high. False negative rate is only 4%. So for a global pathology, the first line investigation of choice is an office endometrial biopsy.
So can I ask you, why do we have this 4 mm cutoff? Why not like a 6 mm or an 8 mm? Because we hardly find pathologies at
a study which said, like, if you have they had 3, 4, 5, depending upon the thickness, the number needed to treat will vary. So they arrived at this conclusion that 4 and 5 mm is a better, to swap between sensitivity and specificity. So that is why you have this 4 to 5 millimeter cutoffs.
Okay, let me put it in a different way. So I feel that when you have a cutoff at 4 in your unit, say, you're literally ruling out 99% of patients who are less than 4 mm will not have a malignancy. So the point of it is, if it's less than 4 mm, you will not miss a malignancy in 99% of cases, and you're safe to tell your patient that she does not have cancer. But the reverse is not true. If you have an 8 mm, I see many gynecologists already prepping up the patient for a possible cancer diagnosis. The positive predictive value of 4 mm is very poor. It does not mean that an 8 mm or a 9 mm is going to have a cancer. To go back to the first slide, only about 10-15% will have a malignancy, even if they present with postmenopausal bleeding, even if they have an 8 mm or a 9 mm. So it's important to keep all these options out there in front of you while you're investigating, and not scare the patient saying you've got an 8 mm thickness, so you might have a cancer. No, the chances of that is still only about 10%. 90%, it could be a benign condition. The idea of having a 4 mm cutoff is that if it's less than 4, we are safe. If it's more than 4, it does not equate to carcinoma endometrium. And I think this language, when we speak with our patient, is very important. And that's what basically the slide says. Ma'am, how do we measure ET?
One second, Anbu. The thing is, like, we also have to tell them that when you reassure them, you're not doing an endometrial biopsy, sending them off. And we need to tell them that if they come back with a, bleeding again, then we still, even if the endometrial thickness is less than 4 mm or 4 mm, we will still have to do an endometrial biopsy.
Got it.
With the recurrent bleeding, then the significance increases even with a thin cutoff.
Without the cutoff. Got it. I'm going to come to that later. Actually, I've got a case like that. How do we measure endometrial thickness? So this was already addressed.
Now, as we are now discussing about the postmenopausal, the endometrium is going to be homogeneous. If it is premenopausal, then you have the proliferative phase and the secretory phase. The endometrium is going to start from a thin layer. Then you have a functional and the basal layer coming up. So you have a triple layer appearance. So that time you have to be very careful measuring the basal layer to the basal layer.
Here you don't have to worry about it.
That is, if you have a triple layer, I just tell you, because all of you will be seeing, other than the postmenopausal, other patients also. So yeah, nicely projected the good triple layer endometrium. What we see in the premenopausal age group who are menstruating. So the central line that you see, it is just because of the opposition of the endometriums. The next dark line, that's the functional layer. And the white line in the base, that is the basal layer. So what happens is when it goes to the secretory phase, the totally becomes white, echogenic, because the functional layer absorbs some water. It becomes edematous. So totally everything will become echogenic, and then so you will have thickened echogenic endometrium. So that's the thing. Here, how you have to measure this from white line to white line. That arrowhead is the correct one actually. So this is for the menstruating woman. But now we are talking about the postmenopausal woman. So it is going to be the homogeneous one. So you are going to see that. And then the important point here is the subendometrial halo. That is because of the myometrium, the thickened myometrium that we say a junctional zone in MR. So here this subendometrial halo will be missed. So if you go back to that previous image that you have shown for the endometrium in the beginning, so that's the wonderful point to teach the postgraduates. So when you don't see that subendometrial, yeah, this is the one which I wanted to, where the mark is put, just look at this. The subendometrial halo is lost over there. See the over that hand area and below that when you come inferiorly. You are tracing. Yeah. So that, below the hand mark, below the hand.
This one.
Yeah. That area, when you trace, there's no junctional zone seen.
Yeah.
When you trace towards the cervix. Yeah. So that's the point that it has invaded the myometrium. So that's the main point to differentiate between a simple polyp and the carcinoma, actually.
Got it. So that's a good point to remember for postmenopausal, that the subendometrial layer is not going to be clearly sonolucent. And it's important to remember that we're not going to see the triple line, unlike in premenopausal women. And it's important to start from the basalis layer to the other.
Another tips I wanted to tell for the postgraduates is when you are not sure of a polyp or something, there is something called in the current color Doppler machines, chroma. That's like, it will be like a 3D yellow color will come in that. So when you switch on that, it will be there in the preset. You just go look for it in your machine. If you switch on that, this polyps will look so bright, white, it will stare at you. So you will not miss the polyps at all.
Got it.
That's another point.
So Kavita already mentioned that we do the PIPL as it's the most cost efficient. Some of the advantages are that we can do it in the OPD. We hardly require any cervical dilatation. The RCOG recommends that if you're doing an outpatient PIPL biopsy, you can prep the cervix with misoprostol, 200 micrograms, and a tablet of diclofenac about half an hour to 1 hour prior to the procedure, as long as there are no other medical contraindications to these two medications. That's straight out the RCOG guideline. And this can be therefore performed without anesthesia or maybe a little bit of local anesthesia. We almost never use local anesthesia for these patients. And the actual sampling time is very less. The risk of perforation is low. As far as the accuracy is concerned, now see, endometrial cancers are what we're worried about. We're not worried so much about the polyps and the atrophy and all of that. And we have to classically remember that malignancies are friable vascular masses. Therefore, when you put in a pipple, you suck it out under pressure, it's going to pull that friable tissue into its cavity and it's going to bring it out for you in biopsy. Therefore, the specificity for malignancy is very high, but this drops down in hyperplasias because in hyperplasias, we don't have that much friable tissue. What are the disadvantages of an office biopsy, ma'am? When do we have to opt for a hysteroscopy, Jayashree, ma'am?
I think we discussed this earlier. We said when there is a non-uniform or when there's a focal thickening, when previous attempts have failed and you've got scanty material, you have to either suspect a polyp or maybe you've not sampled the correct area. So those situations we have to. And if they also, report a highly vascular polyp with a pedicle leading vessel going into it, etc., then, or a large polyp, I may still go in for a hysteroscopy directly.
So polyps, failed attempts, repeated bleeding. Would this be the top 3 reasons for opting for a hysteroscopy? Yeah.
Very rare. For technically not being able to do it is extremely rare. It's not, where I've not been able to negotiate and do it in the outpatient.
Got it. So it's fairly successful in the office, but mostly it's not being able to get enough biopsies or biopsy material or repeated biopsies, or a polyps are usually the reason for a hysteroscopic DNC. And that's what's been given here when you're not able to perform, which ma'am said is very rare. Or if you have insufficient tissue, if you have multiple focal lesions, you have persistent abnormal bleeding, or when you're doing it along with a laparoscopy and you're going to do this anywhere. So with hysteroscopy, we always fear if there is a malignancy inside, will we disseminate cancer cells? Is there a risk that there is going to be peritoneal metastasis? Kavita, what's the data on this? Should we be scared?
No, basically, there may be a 6% chance of peritoneal, fluid positive cytology. It doesn't translate into a poor survival or anything. So there is actually no problem with doing a hysteroscopy in a suspected endometrial cancer.
Okay, so I think that can potentially be put to rest. We do see that there are cells which are picked up when you do a hysteroscopy and go back and you do a laparotomy in this patient a few weeks later. We still pick up some positive peritoneal cytology. Now, the important thing is that peritoneal cytology is not part of the CA endometrial staging because it does not have any therapeutic or prognostic implications. And that has been shown in patients who've had hysteroscopy as well. Long-term follow-up, if they've had a hysteroscopy before, it was not associated with worse survival. So I think technically you can put that to rest. Now, I thought this was a very interesting slide, not just for postmenopausal, but for premenopausal patients as well. These are some of the indications for which you will do a biopsy. As we saw in abnormal uterine bleeding, all postmenopausal patients, once you evaluate with pelvic ultrasound and you're above the cutoff, then you have to do a sampling. This is only sampling. It doesn't say whether to do a Whipple or a hysteroscopy. In 45 years to menopause, if any patient bleeding that is frequent, bleeding that is heavy, bleeding that's prolonged, and if there is intermenstrual bleeding, in younger than 45-year-olds, the high risk factors are BMI, abnormal uterine bleeding that's persistent and occurs along with a PCOS or unopposed, just estrogen, unopposed by progesterone, failed medical management, or high risk for endometrial cancer patients. Then you also need to do it if cervical cytology is showing atypical glandular cells. Presence of atypical glandular cells with endometrial cells seen, you need to do endometrial biopsies. Presence of atypical glandular cells, all subcategories other than endometrial, if more than 35 years of age, and appearance, even benign appearing endometrial cells in those more than 40 years of age, you have to do an endometrial sample. So I just thought I would put it in, even if it's not related to the postmenopausal bleeding scenario. Now let's come to to what we're really worried about and what we want to pick up and reduce mortality is CA endometrium. That's what we are really worried about in postmenopausal bleeding, right? So how common is postmenopausal bleeding in carcinoma endometrium? It's about 90%. 90% will present with PMB. And whereas the reverse, which is what I just said, that if you have PMB, what percentage of women will have endometrial cancer is about 9%. But you want to pick up all these endometrial cancer patients and make sure they are treated properly. Therefore, we have to also focus on the precursors. How common is endometrial hyperplasia and PMB? I don't have the actual numbers, Kavita. What is the data say?
It's around 10 to 12%. So endometrial hyperplasia, including hyperplasia with and without atypia, around 10 to 12% of them in postmenopausal bleeding will land up in you'll have a biopsy result of endometrial hyperplasia with or without atypia.
So you've got 100 postmenopausal patients, bleeding patients, you've got 10% malignancy. So you've got 10% of hyperplasias, right? That's what you mean. So the RCOG says that it's 3 times the incidence of endometrial cancer, which will put it somewhere around about, say, 6 to 10%, I guess, depending upon which population we are talking about. But atypical hyperplasia amongst this is actually only about 1 to 3%. Some studies quote even 0.2 or 0.5%. Again, this is population dependent. It may be low in our country compared to a westernized population. Before we jump into the management of hyperplasias, Kavita, can you quickly tell me what's happened in terms of how to categorize? We still find patients coming in with simple, complex, all of that. What has changed now?
Yeah, so the previous classification, as you've already mentioned, is like when we were all postgraduates, used to have this simple hyperplasia without atypia, 1% risk of 1, 3, 7, and I guess 25%. So complex hyperplasia without atypia, then simple with atypia, complex with atypia. So this was the classification of old classification of endometrial hyperplasia. Then you had the EIN system, which was established 2000, very complex definition of EIN. You had a D score and all that. Now it's become very simple. 2004 WHO classifies endometrial hyperplasia into hyperplasia without atypia, hyperplasia with atypia, atypical endometrial hyperplasia, which is the same as EIN. So these are only two hyperplasia classification, meaning that the ones without hyperplasia have a very, very low risk of progression.
So what is the risk of progression?
That is what, 1 to 3%.
So this one without atypia is about 1 to 3%. And atypical?
It could, see, that varies from 15, generally 15 to 20 or even 40%, depending upon the studies. But then it has got a definite risk of progression. So atypical hyperplasia is purely pre-malignant. So that is that is something that you'll have to remember. And we know that you can have associated endometrial cancers in 40 or even up to 60% in some series. So these are, you have coexistent endometrial cancer when you have an atypical hyperplasia.
So two important takeaways, please talk to your pathologist, whichever lab your report is reporting your biopsies, that they've got to stick to this uniform WHO criteria, which is 10 years back. The complex, simple, all of that is out. No atypia, that's the classification that's in. And atypical hyperplasias are the true precursors for endometrial cancers. So this has already been addressed. Risk of progression, no atypia, it's usually around 1 to 5%. So 1 to 2%. So let's just keep it as less than 10%. With risk of progression of atypical hyperplasia is very high. It's about 15 to 40%. Coexisting cancers can be about 40% of diagnosed EINs. Ma'am, can ultrasound give a clue? Can we actually find out? Jayashree ma'am, I also want to know if you can find this out on hysteroscopy. Can you do a hysteroscopy and just say this is hyperplasia? And Devi ma'am, can you say this is hyperplasia on ultrasound?
Yeah, actually, most of the time, hyperplasia, when the result comes in retrospectively, you go back and see, it will be a uniform thickening with multiple tiny cystic areas.
And that's typical, atypical?
Atypical, typical that we can't make out, but I can say with the kind of an experience, it's not really scientific or something. It's like a thickening of the endometrium with the uniform thickening, and then there's multiple tiny cystic areas. The cystic areas almost, it will be similar. It will not be like a different kind of the cyst. So that's the thing that you think
uniform cystic pattern.
Yeah, uniform cystic pattern will be there.
Jayashree ma'am, hysteroscopy, hyperplasia.
At hysteroscopy, hyperplasia apart, if there is a definite carcinoma, then you can certainly see multiple blood vessels, some of them hanging loose in the cavity and your saline pushing it up, etc. Can be made out mostly. But hyperplasia, I think not that easily made out. But when you actually curate and remove the material, you do get a clue as to whether it's going to be it's not going to be normal is what you can make out. But making a diagnosis of hyperplasia as such, I don't think, not on hysteroscopy.
Yeah. So unlikely that ultrasound will give us a clear clue. So far, we do not have markers on ultrasound to tell which could be a hyperplasia. Out of experience, ma'am says that cystic spaces could give you a potential clue. Similarly, for hysteroscopy to give you that bang-on diagnosis of hyperplasia, we still don't know. It could range anywhere between proliferative to endometrial hyperplasias. So
many ultrasounds, Anbu, many ultrasound reports come as endometrial hyperplasia. I think
that's why I asked that question.
That's something we need to watch out against. We should not be reporting that.
That's the reason I asked that question.
So only the endometrial thickening, actually.
Yeah, that's fine.
That's
Yeah. I just got a report this morning saying
That also with the different papers, there's different, few papers says the proliferative phase 8 millimeters and then the secretory phase 16 millimeters. But commonly people use 12 millimeter and above endometrial thickening.
We are talking of postmenopausal bleeding.
Yeah.
Postmenopausal, right.
I think what the radiologists should do is just report on the thickness.
Endometrial thickening alone.
Patients. And there is still no clear-cut evidence. We're talking evidence. There's still no clear-cut evidence. Unlike the ORAT score, there is no score to categorize hyperplasia on ultrasound or on hysteroscopy. So what is the management of endometrial hyperplasia? We already saw in the multiple choice questions that you can use for non-atypical hyperplasia without atypia. What is the management protocol, Jayashree ma'am?
We would probably give a choice of progestin therapy, either oral or you can go for the LNG-IUS. So you'll have to counsel the patients. Personally, I would actually go for a short course of oral first before I put them onto the LNG. Because need to see how they are responding, need their compliance, etc. Now, long-term progestin therapy compliance then becomes an issue after a few months. So if they are responding and they are responding as in there's no breakthrough bleeding, then an LNG-IUS is definitely a treatment of choice.
So the current evidence, at least I know you're talking it from a very practical point of view. As soon as you see a report, you may not be able to prescribe an LNG-IUS because the patient's probably going to run away. But what the data actually says is meta-analysis, 7 randomized trials, shows that LNG-IUS is the most effective way for treating endometrial hyperplasia without atypia. You had higher response rate at 6 months. So even if you want to wait for that 6 months, see if she's tolerating and all that, even at the end of 6 months, if you had inserted an LNG, you're going to have better response rates compared to oral progesterone. This is talking from a molecular level. And also there's lesser chances of hysterectomy rate. But
6 months
simply,
is too long. We don't wait.
Sorry, ma'am?
So we don't wait 6 months. I think you just initiate it until
I think
recently.
This is more from the UK perspective where they come back only once in 6 months. Our patients come to us more often. So we are usually seeing them in first month after initiating oral progesterone. We see them for compliance and side effects. And then if they're okay.
Before we start them on any kind of oral medications now, especially when we are in the government setup, the patients generally, they do not come for follow-up. They really don't come for follow-up. And so these patients, we also have hysterectomy at the back of our mind, because the problem is a lot of times the report of benign, there will be a preoperative report of benign hyperplasia without atypia. It's practically speaking, apart from guidelines, the final histopathology turns out to be CA endometrium. A lot of times we've seen this. So, so it depends on the patient. If you really think the patient will come to you for follow-up, definitely, and then you could put them on medical management. If you think the patients will not come for follow-up, then hysterectomy is also a choice, especially in the government setup. Postmenopausal bleeding, thickened endometrium, and hyperplasia without atypia is still a choice for hysterectomy in our set of patients. So,
I'm going to disagree with you on that. Because
yeah,
that's, I think, at one end of the spectrum, spectrum, the government is now asking us for lists of hysterectomies of indication, right? And therefore, if we want to follow evidence-based, which I know is very difficult, but I think it's a mindset thing as well, I would still say stick in a Mirena. Stick in a Mirena coil if you're still worried about her her coming back for follow-up and her being lost for follow-up. I think it's safer to do the Mirena or the LNG-IUS, which has a better safety profile, may not require follow-up for the next 2 to 3 years. And if there is recurrent bleeding, she will come to you. If you're worried about the 6 months protocol of following them up with biopsies, hysterectomy, I think, is an overkill. Just my personal opinion, but we're all different practice settings. So what works for you, you do you. But this is what data says. Relapse rates are lower, better compliance. And even if they were followed up after 5 years, they showed lesser relapse rates with LNG-IUS. Ma'am, if you give oral progesterone, what's your choice?
Usually you need to give higher doses. So that is, again, another reason where compliance becomes low. Either medroxy or megestrol acetate is what you have to use. And the dose is much higher than what we use for AUB, etc. So
Yes.
one is the affordability also.
This is what is preferred apparently. So this was news to me as well, because I don't use megestrol acetate so much in postmenopausal bleeding. I use mostly LNG-IUS and combine it with medroxyprogesterone acetate. Now this comes from the fact that megestrol acetate is better with inducing response as compared to medroxyprogesterone acetate and norethistyrone. So this is what the guideline says. This is from the SOGC guidelines, which says that your preferred treatment for postmenopausal patients with endometrial hyperplasia is levonorgestrel. If the patient declines LNG-IUS or cannot tolerate, megestrol acetate is the first alternative compared to medroxyprogesterone acetate or norethistyrone or micronized progesterone. And this is basically because molecularly, megestrol acetate is better at inducing responses. Second thing is it's better tolerated. That's for sure. Even if it's a 160 or a 320 milligrams, it is better tolerated than a medroxyprogesterone acetate or a norethindrone because the water retention is less with megestrol acetate. So you might want to give megestrol acetate a little bit more. It's possible, it's possible to prescribe this and it's high on the list. So if you're not using it, it may be time to start prescribing it for a few patients and seeing what your experience is. With atypia, Kavita, that's where I would agree with you on hysterectomy.
Obviously, hysterectomy. When here again, I go one step forward because ideally speaking, so we did a study in our center. There was 60% stage of upstaging to endometrial cancer. So we do some kind of lymph node assessment, at least a methylene blues. I mean, we don't have a ICG, so a central methylene blue at least we do when we have atypical endometrial hyperplasia.
So I'm going to reverse the question here. I find that a lot of patients who are diagnosed with endometrial cancer, young, from IVF centers, infertility, these doctors are very quick to put them on progesterone. Is that the accepted treatment? Can you comment on that? Because I think in this case, I'm seeing a reversal. We are quick to do hysterectomies for proliferative endometriomas in postmenopausal bleeding. I understand there's a big concern for IVF patients to preserve fertility, but we need to pass on the message that that is not the recommended treatment. It's out of recommendation, right? So what do you usually see?
See, I see a lot. See, they are already already started on progesterone, and the progesterones are, they are low dose. They are not megestrol. They put them on 10 milligram, medroxyprogesterone for a month, 2 to 3 months with atypical hyperplasia, not evaluated. And then with, the patients not responding to treatment, and then they are referred. So this is what is scenario now. That's not the standard of care because you know that you do have an associated risk of endometrial cancer. So management of fertility preservation in case of atypical endometrial hyperplasia is, you need to have a lot of discussion with the patient. First thing is you must do an MRI to rule out a myo-invasive endometrial cancer. It could be an endometrial cancer with myometal invasion, and that time your you really
management
cannot
and staging managers.
Point over here, actually, whenever you see younger patients with the endometrial CA, we could pick up lesions in the other regions like colon polyps. So when they go for the biopsy of those polyps, it also has malignant potential. So it comes under the syndromes. So younger patient always have that in mind that as the molecular this thing is also coming up, you can also plan for the hereditary cancer gene panels also. May save the family people in that case.
Agreed, ma'am. So
can we wrap up?
Care?
Anbu will be wrapping up in 5 minutes. Can we do that?
Yes, done.
Coming up to 7.
So I'm going to just come up with one. We've talked about this particular scenario where repeated endometrial biopsies happen, and the panel agrees that we are going to do a hysteroscopy. Now, what do you do about women who come from master health checkup with an endometrial thickness? What is the role of doing an endometrial biopsy in those patients who do not have uterine bleeding, but who have an endometrial thickness that's increased, that is picked up usually in a health check. So what is the evidence say, Kavita? Quickly, if we can just wrap it up in
You
5
put that up. So when you have an asymptomatic woman not bleeding, the endometrial thickness of more than 11 millimeter, will compare with that of your postmenopausal bleeding cutoffs of 4 millimeter. So generally, the recommendation is that if you have a thickness of more than 11 millimeter, you need to biopsy this patient, but you need to take the patient on a case-by-case basis. Even we've seen cases of endometrial cancers even with 8 millimeter thickness. So you have these intermediate risk patients, that is obesity, whenever they have this chronic anovulation, corpus cancer triad, PCO, all of them, the obese patients, then you may choose to, you can, talk to the patient and you can decrease the threshold to less than 11 millimeter also. But then asymptomatic, very low risk women, more than 11 millimeters is the cutoff for endometrial biopsy.
So I think that's sort of something new that I came upon, that the Canadian guidelines, the ACOG, all of them for this reason, that when it is more than 11, it equates the incidence of endometrial cancer to about 6%, which is the same rate of picking up when a bleeding woman is more than 5 mm. And therefore, they say more than 11 mm or increased vascularity or inhomogeneity or particulate fluid, all of this should undergo further evaluation. Just one last question. So, ma'am, Jayashree ma'am, if you have endometrial biopsy and it shows a proliferative endometrium, what do you do?
In a postmenopausal woman?
Yeah, you do a biopsy and it comes out as proliferative.
Suggestion that there is some estrogenic activity going on. So we need to probably try to find a source, which usually on questioning may be some medication that she's taking. Very obese women also, we can see this sometimes. So we need to go further into the history and see. If everything is negative, we can just follow her up, keep her under observation, repeat her endometrial thickness, and then take a call on it.
Yeah, so even with women, postmenopausal women, proliferative, even though it's benign, it has been shown that some sort of a carcinoma diagnosis could happen in 5 or more years if this is left uncorrected. So like ma'am said, correcting any risk factor that could potentially be present and keeping these patients with proliferative endometrium, they have a 4-fold increased risk of developing endometrial hyperplasia, keeping them under your follow-up, or in Kavita setup, doing a hysterectomy.
No, not for a proliferative endometrium, please. But then
that might be something that you want to consider. Finally, one last question, please, Meera, if you can. I want to ask Nitya a question. I'm really sorry for not involving her in this panel. It just didn't leave me any clinical situation. So we've talked about this in the lecture, but Nitya, do you really use this?
Yes, in our setup, early, of course, one thing I would like to tell everyone is most of our endometrial cancers are diagnosed in stage 1. And we normally go for brachytherapy once the stage is beyond 1B, and addition of external beam radiation once we find the higher staging. So there are many times when we find the patient comes back with a vault recurrence after a few years, despite being stage 1A. So that is when the need for a molecular subtyping came into being. So as you've already explained in detail, there are 4 subtypes of endometrial malignancy. So the molecular test for these 4 subtypes is now available in plenty. We have at least about 10 to 12 labs doing it. The turnaround time is around 3 weeks, and it is not very expensive. The main purpose will be to upstage or downstage the disease. So we are trying to optimize treatment for stage 1 and stage 2, just to make sure that they don't have any kind of a local recurrence. So if, for example, a simple example I would tell, if you have a pole mutant, which is the ultra mutant, if you have a pole mutant stage 2, you can actually downstage to stage 1 because they have an excellent prognosis. They do not have any risk of recurrence. So just by being stage 2, you don't have to offer them EBRT. So in the same scenario, in the same exact opposite scenario, you have a stage 1 with P53 mutation. You have to upstage. So that is the basic implication of a molecular testing presently. And we offer this to all stage 1 and 2 patients, along with a very good interpretation of the lymphovascular space invasion, which is also one of the very important factors for risk stratification as well as staging. Now the staging is pretty extensive, And as you said, we really cannot remember. And there are some algorithms which we can follow over internet. They have AI-based calculations to find out the risk for these patients. And the basic idea is to optimize the treatment, because most of the patients do not receive any treatment. We've hardly seen any patients in stage 3 or 4. Maybe in the last 15 years, I've just seen about 4 or 5 patients in stage 3 and 4 endometrial cancer.
I would agree.
So the main issue is the stage 1, which is recurring. So that is one thing. The other thing is the clubbed cancers. We have the MSI high tumors where we have a higher risk of Lynch syndrome as a part of it, where we have colorectal malignancy. So it helps in screening. In advanced disease, molecular subtyping, yes, not just the molecular subtyping, but the MSI status is also going to be important to determine whether the patient is going to be eligible for immunotherapy, because that is the most sensitive marker for immunotherapy in endometrial malignancy. In other solid tumors, we look at PD-L1, but in endometrial malignancy, it is clearly MSI status, which dictates the need or no need or the utility of immunotherapy when there is a recurrence in such a setting. As you said, pembrolizumab with lenvatinib, one of the magical combinations. We have two patients presently on the combination, and the disease is practically gone in 3 months. So that is the utility of molecular subtyping right now. And I think it should be done for all patients, just to at least optimize the treatment. It is very much available. I think we just have to approach the lab, get a good sample. The block should be available, stored. I think we should just start doing it to know more about the molecular analysis.
So got it. With that, I think that's a good wrap up. You've kind of put all the points that molecular subtyping can help with in one nutshell. And thank you so much to the organizers. I hope we added some value to your clinical practice through this panel. Thank you for this opportunity.
It was a wonderful panel discussion, highlighting the practical points very clearly. I thank the moderator and the panelists for their effort.
Thank you. Can Sahiti please project the answers on the winner of the quiz?
The 35 people have attempted the quiz. So it is really nice. I think it is catching up. And wow. Sahiti, can you post? Ramya, I will just ask her to. Sahiti, are you there?
Yes, ma'am.
Yeah, can you?
Yeah, she's doing that.
Okay, ma'am.
One person has got all the answers correct. I congratulate Dr. Ramya Ramadas, who has got all the 5 questions, all the answers correct. And 3 more have got 4 answers correct. But Rani was the fastest. Rani Pia, Subhashri Prakash, and Puviri Selvam. And Rani Prakash was the fastest. So I congratulate all the people who attempted the quiz and the winners too. It was really encouraging to note that so many people have attempted.
Shanti, can I have just one word, Shanti?
Yes, madam.
Can I just have one word? See, this Chennai Menopause Society, it was started in 1995 by Dr. Indra Ramurthy with Jayashree and Geeta Arjun. Okay, but only in the last few years, you, Hepsi, and Meera have taken it to phenomenal heights. Very proud of all of you. Please carry on. Very, very proud of all of you, Shanti, for doing such great work.
Thank you, madam. It was our founder secretary who was sitting there as a panelist, and then founder president first as chapter.
Yes, Jayashree Gajaraj. Yes, Jayashree. She's always an expert in what she does.
Very thankful to Dr. Jayashree Gajaraj for having initiated. Initiation will be such a big problem. Continuing is not a big thing, but initiation is a big problem. And
not that, Shanti, you have really taken it up to phenomenal height. Chennai Menopause Society is one of the highest level. Really congratulate you on it.
Thank you all. Thank you very much. And it was really a very...
We have a surprise element for everybody with closing remarks from our president as well. Sahiti,
yes,
can you please put the online flip book?
Sure, ma'am.
I would like to congratulate and commend Dr. Dhanalakshmi for putting this flip book, which everybody can use. This is a Quizzes Digest, a compendium of all the quiz which have appeared so far, so that it'll be useful for people while you're traveling, while you're, flipping on, so that it'll be useful for preparation for the CIMP as well. So 50 questions with their answers. So as a flip book for you. And we will be giving more and more as we collect our quizzes as we go on our weekly midweek quizzes.
We have on every Sunday, we have the IMS quiz. Then Chennai Menopause Society, we have a midweek midlife quiz on Wednesday. And that is really catching up. We want everybody to be really empowered. So only that is the reason why this has been shared with everybody, so that you all can utilize it. And people who are attempting SIMP exam will really find it very useful. Okay. So it was really a very nice academic session, and so many learning points. First from Kavita about CA 125 and CA ratio. Then that germ cells do not, you need not evaluate for germ cells in postmenopausal women. Very good carry home messages. And Anbu's talk was teeming with lot of messages. It was really very interesting, and you categorically told about the MRI being very helpful, and genetic evaluation is mandatory, and molecular profiling. That is what Nitya, she also, our medical oncologist, Dr. Nitya, also talked about that. That was really very interesting, changing the treatment profile, as well as so that the patient's comfort also increase the grade. We are not overdoing it or underdoing it. So many times, as said repeatedly, even stage 1, we have seen vault recurrences. So all these things can be overcome with molecular profiling. And it was interesting to note about the sentinel node sampling mapping also. So that was also very interesting. And this panel also had a galaxy of experts, right from Jayashree, then coming to Devi Meenal, then of course Kavita and Nitya. So it was really very interesting, and there were a lot of messages, and I thank Anbu for the good moderation. So it was a very satisfying academic program, I feel. So I thank all the people who have made it possible, and also the delegates who have attended, and the quiz. We are really very happy that many are attending this quiz too. So thank you very much. And so Ramya, can Ramya show herself up? Are you still there? The person who got all 5 correct.
Madam, people also wanted to know the answers, madam.
Yeah. We will post it in the group if that's okay. Or Sahiti can post it now. If that is a problem, we'll post it in the Chennai Menopause Society group if that's okay.
Oh. Sahiti, is it possible to just flash it for a minute?
Yes, ma'am. Sure, ma'am.
Thank you, Sahiti.
We are, I'm very sorry we started late, and then it has extended also. We have taken up too much time. I'm very sorry about the timing. Okay, just flash that thing, answer alone.
Yes, ma'am. Just 10 seconds, ma'am. I'll.
Though it has gone longer, I think all of us have been now upstaged to be gynae oncologists. Thanks the eminent speakers, the panelists, and the moderator.
Yeah.
Thank you.
Thank you, Meera. Thank you, Meera, for organizing such nice programs.
Yes, ma'am.
Thanks, Sahiti.
Thank you, ma'am.
So metastatic ovarian tumors are suspected when CA125, CA ratio is less than 25, bilateral solid ovarian masses, ovarian cysts, with evidence of pseudomyxoma peritonei. So all of the above. Next, Sahiti. The following statement is true with regards to CECT abdomen and pelvis. So CECT abdomen and pelvis is the preferred modality of
the last question.
Yeah, when a patient has an advanced. Next. A 35-year-old woman with a BMI of 28 kg per meter squared, presents with polymenorrhea and abnormal uterine bleeding. Analysis of a direct biopsy of the endometrium shows well-differentiated, normal-shaped cells with an increased gland to stroma ratio. So the diagnosis, most likely diagnosis is endometrial hyperplasia without atypia. Next, the most preferred line of management for non-atypical hyperplasia is LNG-IUS. That is very, very important. When LNG-IUS was introduced, they said it will avert hysterectomy to a great deal. I think we should make it come true. The risk of coexisting malignancy in a case diagnosed as atypical hyperplasia of endometrium on endometrial biopsy is 15 to 40%. Okay. Thank you very much. And Ramya is there. Ramya Ramadas, can you show yourself up? I can't see.
Ramya.
On your camera.
Yes, ma'am.
Yeah.
We'll have to pin her.
Putting up your hand.
Ma'am, you can talk, ma'am. I have given the access for you to talk and.
One second. On your camera, we will have a photo and then call it a day. Yeah. All of you all switch on your cameras, please. Ramya, congratulations. I hope. Dana, please.
Ma'am, please unmute, ma'am. Ramya, ma'am.
Yeah.
Thank you, ma'am. It was a very wonderful session. It's also worth the time, ma'am. I enjoyed the session, ma'am. Thank you so much, ma'am. So much informative also and interesting also, ma'am.
Congratulations.
Thank you, ma'am.
Congratulations, ma. Wish you more and more success.
Thank you.
Jayashree, how are you?
I'm fine, ma'am. Thank you.
Nice to see you, Jayashree.
Thank you.
Yes, ma'am. I have clicked a few pictures, ma'am.
Thank you.
Thank you.
Then see you again in another academic program.